I know that today's topic will bring up a number of questions from you. So you may type your questions in chat box and I want to let you know that we will address as many as we can in the time we have today. And I welcome and request our NBMS National Webinar Coordinator, Professor Dr. Mahesh Goenka, to start this session. Thank you and over to you, sir.
Good evening, Mr. Singh. And we are today, I was just looking at the list, and we are on 98 of the online weekly DNB classes. We started somewhere in the beginning of 2020, just when a couple of months after the COVID started. So we'll be having a 100th class about 2 weeks from now. But let's now look at today's meeting. And it's first time I think we are at the GEM Hospital, Coimbatore. And we have Dr. Junaid Khan and Dr. Sridhar as the resource faculty today to take us through this program for 1 hour. Over to you, GEM Hospital, Coimbatore.
Thank you, sir. First of all, initially, I'd like to thank Dr. Goenka, sir, and the NB board and my coordinators and my moderators to give me the opportunity to present this case. I'd like to present a case of a 52-year-old male who is a resident of Salem, Tamil Nadu, MSc graduate and teacher by occupation. The history was taken from the patient himself and his wife, so thus the history was reliable. He presented to us with the chief complaints of yellowish discoloration of eyes and urine since 15 days, mild generalized itching since 15 days, abdominal distension since 7 days, and bilateral leg swelling since 5 days. There was also a history of significant abdominal pain since 3 days. Coming to the history of presenting illness, the jaundice was noticed 2 weeks prior. Prior to the admission, it was insidious in onset, associated with nausea, mostly patient noticed postprandially, but no generalized fatigability. Initially, patient noticed the high-colored urine and later noticed the yellowish discoloration of eyes and skin. The jaundice was not associated with chills, rash, arthralgia, vomiting, and there was no associated GI bleed, giddiness, or associated sweating. There was no history of any long-term drug or over-the-counter drug intake, no history of consumption of any native medication intake. The history of itching was present for 2 weeks. It was also insidious in onset, started in the palms and soles and later became generalized. It was mild in severity, more in the night time, associated with sleep disturbance, but there was no associated skin eruptions or waxing and waning in the severity of this itching. The pruritus did not affect his daily routine, and it was not relieved with the topical medications prescribed to him, but it was also associated with mild dryness of skin. The history of abdominal distension was present for past 7 days. It was subacute in onset, generalized, gradually progressive, associated with mild loss of appetite. Patient also noted bilateral lower limb swelling, which started 2 to 3 days after the onset of this abdominal distension, and initially it was noticed only in the ankle region. There was also a history of mild reduced urine output noted just before the onset of abdominal distension. The abdominal distension was not associated with any facial puffiness or breathlessness on exertion. It was not associated or relieved with the passage of stools or flatus, and no aggravation noted after any food intake. The history of abdominal pain was present since 3 days. It was mild to moderate in severity, gradual in onset, persistent deep dull aching in character, lasting for around 15 to 20 minutes, which subsides only after some pain medication. It was located in the epigastric region but not radiating to the other regions of the abdomen. It was aggravated by food intake, and there was no history of any definite relieving factors like aggravation by the change in posture or relief by the stooping forward. The pain was not associated with any vomitings or altered bowel habits. There was no history of any trauma or the awareness of any abdominal lump. For these complaints, patient was evaluated by a gastroenterologist in his hometown and was advised to visit a center with a liver transplant facility, for which patient visited our hospital. Coming to the history of last admission, as it was significant, being a patient giving a history of similar complaints 1 year back when he developed pain abdomen, which was also located in the upper abdomen, more in the midline and the right side, mild to moderate in severity. The pain was not radiating to the other regions of abdomen with no postural variations, and it was aggravated by food intake and relieved with the analgesic. There was also a history of jaundice for 3 weeks, which was acute in onset and progressive. There was, the differentiating point being there was no itching or pale stools noted at the last episode of this jaundice. There was no associated prodromal symptoms, including fever. Jaundice and pain abdomen were preceded by history of binge alcohol consumption 1 week prior to the onset of all these symptoms. The history of vomiting was present for 5 days. It was acute in onset and no hematemesis. The character of vomitus was non-bilious, containing the semi-digested food particles, and it was not associated with abdominal distension or altered bowel habits. Initially, for these disorders, the patient consulted his family doctor and then was referred to a nearby gastroenterologist, where imaging and endoscopy was done as per the patient's history, and diagnosis of some chronic liver disease was explained to him. But old records are not available. He was started on some oral medications for which the prescription was also not available, with which his symptoms improved, and he was later discharged after 1 week of admission. Patient took this prescribed medication for 2 months and then stopped himself without consultation after improvement of symptoms.
So, can we, can you complete the history and then give us some analysis?
Yes, sir. Yes, sir. There was no history of any altered sensorium, pale or silvery stools, constipation or weight loss, breathlessness in lying down position, cough or wheezing, tattooing or any IV drug abuse, high-risk sexual behavior. There was no history of any recurrent oral ulcers, dryness or irritation in eyes, night blindness, bony pains, ataxia, or any easy bruisability. There was no any other significant comorbidities except for the diagnosis of chronic liver disease, which was explained to the patient and his relatives 1 year back. There was no history of any surgery or trauma in the past, no history of hematemesis, bleeding PR, or melena and altered sensorium. Personal history, patient takes mixed diet with a calorie intake of 1500 kilocal per day and a protein intake of 40 to 50 gram per day before the onset of all his symptoms, compared to which there was a significant decrease in appetite since 2 weeks, after which he started taking around 900 to 1000 kilocalories per day intake and 20 to 30 gram day protein intake. The calorie deficit calculated was around 800 to 1000 kilocalories per day and a protein deficit of approximately 50 to 60 gram per day. Bowel and bladder habits were normal. Sleep was decreased since 3 days, which patient attributed to his generalized itching and mild pain in abdomen. There was history of alcohol use disorder since 12 to 15 years with 3 to 4 units of whiskey per day, which accounted to around 40 to 50 grams with last consumption 1 year back. There was also a history of binge drinking in the past noted, and the patient is a definite case of an alcohol use disorder with his audit C score being 7 and a CAGE score being 3. There was no history of any smoking or tobacco abuse. Treatment history, there was no history of any prolonged drug intake except for the drugs prescribed during his last admission, which patient took for last 2 months. Other than that, there was no history of CAM, native medication or OTC drug intake. There was no history of endoscopic procedures in past, blood transfusion and large volume paracentesis. Patient took his first dose of COVID vaccine in the month of July 2021, 2 months prior to the onset of his admission. Family history was not significant except for his one sister dying at the age of 18 years in the year of 1990, for which the cause was not evaluated. But there was, other than that, there was no history of any jaundice or liver disease in family members, no history of gallstone or other any metabolic traits in the family. The pedigree chart was also not showing any genetic association. To summarize my case, this is a case of a 52-year-old male who is a known case of a chronic liver disease and alcohol use disorder, who presented to us with a history of progressive jaundice since 2 weeks, pruritus since 2 weeks. It was complicated by ascites, decreased urine output since 1 week, and pedal edema since 5 days. There was also a history of significant abdominal pain since 3 days, but no history of any fever, prodromal symptoms, GI bleed, and hepatic encephalopathy.
So Sharma, you are wanted to tell us a CLD case with what reason for cholestasis? You think it's intrahepatic or extrahepatic?
So,
Sir,
if we can go into it, that can you just analyze this history? It's a very, very interesting and well presented history. But rather than labeling this as a case of chronic liver disease to start with, as you have done in the summary, I think let's analyze the case and look at your possibilities at this stage.
yes, sir. So
How do you explain the whole chronology as asked to you, that so we know that there has been a prominent cholestasis. This is a cholestatic jaundice. So how do you look at it, whether it's intrahepatic cholestasis, extrahepatic cholestasis? Why do you say it's chronic liver disease? Let's not just go by what patient told you, that he was told that there's a chronic liver disease and he needs to go to a liver transplant center. I think let's analyze the history.
Yes, sir. So so first point in the favor of his chronic liver disease was patient was evaluated by some ultrasound imaging as well as endoscopy, and he was told because of his alcohol use disorder that he has to stop his alcohol as it has led to his.
See, I would suggest you that let's not go by your starting and labeling as chronic liver disease, because unless you have gone through the records, I would not, for the examination point of view, you are going to appear for your exam. I would not start with saying that this patient has a chronic liver disease because he was told that he has a chronic liver disease, because an ultrasound was done, because an endoscopy was done, and he was told that he has a chronic liver. Let's just look at what you have in your presentation. Dr. Khan, you agree with me?
Yes, sir. We can present as a basically cholestatic hepatitis,
Yeah,
and then we went
two episodes possibly.
Yes, sir. Okay.
Then we can differentiate whether it is intrahepatic or extrahepatic. That is more important.
Yes, yes, sir. Okay.
So there are two distinct episodes of jaundice, isn't it?
Yes, sir. There were two distinct episodes of jaundice present, sir.
With a gap in between.
Yes, sir. With almost a gap of 1 year in between, sir.
So what are your possibilities?
Sir, it can be.
You just forget about patient telling you that it's chronic liver disease, it's alcohol. Those will come later on. But if you are not given those data, how will you analyze this history?
It is a case of a cholestatic hepatitis, sir. The prior episode was more towards an hepatocellular jaundice, sir, with no episodes of any pale stools or and generalized itching of pruritus, sir. But this episode, patient had a definite generalized pruritus, which was affecting his daily routines as well as disturbing his sleep pattern. It is a case of a chronic cholestatic hepatitis, and being a year gap of around almost 1 year, most likely to be a benign disorder, sir, which can be intrahepatic as well as extrahepatic, sir. The intrahepatic common causes can be viral, drug, or the patient continues to take the alcohol intake or any other native medications. And the extrahepatic being, it can be any other cholestatic disorder like sir IgG4 related disease, or PSC, or even choledocholithiasis, sir, if the patient is not giving a history of chronic liver disease, like a definite history.
So what is your first possibility, second possibility, third, fourth, and fifth possibility? Give us 4 or 5 possibilities from whatever you have presented.
Sir, I'll go to my differential diagnosis part, sir.
Next slide, Sharma, you show your differential points now.
So coming to the differential diagnosis, considering this index, this episode, it can be a benign intrahepatic cholestatic jaundice, the cause of which being a viral, alcohol, or any other infiltrated disorders, including the drugs. As the patient gave a history of chronic liver disease, we kept the possibility, kept aside this possibility for some time. The other possibilities can be an AIH-PSC overlap. It can also be keeping in mind a significant pain abdomen history, sudden onset of ascites. It can be a vascular disorders, including an acute Butchery syndrome, or a benign biliary obstruction like IgG4 related disease, or a simple PSC, and the rare possibilities of intrahepatic malignancies or metastatic carcinoma to the liver, as well as the malignant biliary obstruction can also be kept because there was no history of any fever or cholangitic symptoms present, with no history of any significant weight loss.
Now, I have a little bit of objection to your terminology used in your first differential diagnosis. Benign intrahepatic cholestatic jaundice. Now, this is a term which is used for a particular specific disorder, benign recurrent intrahepatic cholestasis. So if I would have been in your place, I would have said a case of chronic liver disease with superimposed viral or alcoholic hepatitis.
Okay, sir. Okay.
Now, term benign intrahepatic cholestatic jaundice is not used, to my knowledge, so far as I understand, for viral hepatitis or alcoholic hepatitis. Dr. Khan or anybody wants to comment on that?
I have a similar objection to it. I would go with you. Sharma, you presented the whole case in a fashion that it's a chronic liver disease. And in the differential, why bringing in a new set of etiologies? You had a clear-cut cage score, you had a clear-cut history. So rather than focusing on the etiological differentials, shouldn't you have already go to the previous slide, please?
Yes, sir.
You have already got a syndromic diagnosis in situ, and you were going ahead with a chronic liver disease etiology. It's quite clear, but the differential, you've not focused on the precipitating factors. Why has he developed a new onset jaundice? And you have given a clear-cut history of cholestasis. So what are the precipitating factors which can present with the cholestatic picture on a background of CLD should be your differentials in your mindset. That shows your thinking process. Shouldn't it be?
Yes, sir. Yes, sir. Sir, because I kept it like this, sir, because there were two distinct episodes, sir, and the both, sir, the prior episode favored more like a hepatocellular type of a jaundice, but this episode was more in the favor of a cholestatic type of jaundice, sir. So that's why, sir, I would like to I kept aside these all differentials. The acute insult, as you told, sir, it can be a viral or a bacterial sepsis, sir, which can present as cholestasis, any acute viral hepatitis being a hepatotropic virus most commonly, as well as the alcohol related disorders, sir. Alcohol also can have a cholestatic hepatitis. The other causes like the vascular drugs and all, they are more in favor of a hepatocellular type of jaundice, which can have an acute insult in a pre-existing liver disease.
So I think you have, as Dr. As has been pointed out, your one diagnosis is chronic liver disease. Now you are trying to give an etiology of chronic liver disease, and then you are talking about what led to the recent deterioration. So there are three components. One is the chronic liver disease, the etiology of chronic liver disease, and a cause for acute deterioration.
Yes, sir. Yes, sir. That's what, sir. Like three different, sir. Being an alcohol use disorder patient with with a prior admission, having different set of histories, and now presenting with a different set of histories, sir.
So why did you bring acute pancreatitis in this? I want to know what makes you think about acute pancreatitis. This looks a little odd to me. You said the pain is not like that of pancreatitis. Is it only to explain the pain?
There are distinct possibilities, sir, as it can be an life-threatening event, sir. So just for a differential diagnosis, sir, like because the pain was also not getting explained by any intrahepatic causes of cholestasis, sir. So no any benign.
But can you explain the pain by the other three possibilities which you have put forward? Spontaneous bacterial peritonitis, portal vein thrombosis, and hepatocellular cancer.
Yes, sir. Yes,
all of them can cause pain.
Pain abdomen. Yes, sir. All three can be a definite possibility of pain abdomen, sir.
There are few chat box questions, Dr. Junaid. One is that can it be choledocholithiasis complicating a CLD? Number two, can you call it ACLF as a syndromic diagnosis?
Sir, choledocholithiasis can be a rare possibility, sir, but the absence of fever and a significant jaundice, sir, with the absence of fever only, sir, we have kept it as a differential diagnosis, but not as the first diagnosis because other prior history of any gallstone disease in the family member or any other metabolic traits were absent in this patient.
How many percentage of patient with choledocholithiasis you'll get genetic history or family history? That is not a good logic to put. I agree that the whole illness does not fit into choledocholithiasis, but you said that there is no family history in a patient as a negative point. I think for choledocholithiasis is not correct. Dr. Junaid?
Actually, because only thing is against choledocholithiasis is there is not typical cholangitis, pain in abdomen with fever. Those episodes are not there, sir.
Yes.
Okay, let's go forward then.
Yes, sir. The points favoring all.
But I would again re-emphasize the point that your syndromic diagnosis should fit into your differential diagnosis. They are absolutely dissociated from. I mean, your syndromic diagnosis is all correct. So I would have put it in a little different way. But then your differential diagnosis become too wide to reach from that syndromic diagnosis. All right.
Okay, sir. Coming to the points favoring all these features, the points in favoring and point against, the first being the intrahepatic cholestatic. It was a cholestatic type of jaundice with a short progression. It can be a viral or an alcohol-induced cause, but with the presence of pain abdomen and the absence of any prodromal symptoms were against this. It can also be an AIH PSC overlap as the age fits. He was a middle-aged man with a known case of CLD and now presenting with prominent cholestasis. But the absence of any cholangitic feature and overt IBD features were against this diagnosis. As PSC patient, we know 70 to 80% are having concomitant IBD symptoms present. The third possibility can be an acute Butchery syndrome, as the patient had pain abdomen with a significant acute onset of ascites. But the literature shows that the data is very much skewed against acute Butchery syndrome in an acute presentation, as the male to female ratio is around 1:12. And it also presents as an hepatocellular type of jaundice, but in our patient, there were predominant cholestatic symptoms present. The other possibility of IgG4 related sclerosing cholangitis can also be taken, as he was a male patient around 40 to 50 years of age, with now presenting with cholestatic hepatitis. But the absence of any extrahepatic organ features and the absence of weight loss were against these findings. The rare possibilities of intrahepatic malignancy presenting can also be taken, as the patient had a pain abdomen, ascites, and anorexia, but the absence of any weight loss and the cholestatic features are against it, and only around 10 to 12% of the HCC can present like a cholestatic symptoms. Where rare possibilities of malignant extrahepatic biliary obstruction like cholangiocarcinoma was also considered, as patient had a cholestatic features with pain abdomen with no fever, but the points against it were absence of any weight loss, ascites, and the rapid progressive history. Coming to the general physical examination, patient was conscious and well oriented to time, place, and person. His height was 175, weight of 70, BMI of 22.9, and a corrected BMI considering his ascites as well as pedal edema was 19.4. He had a mid-arm circumference in the right upper limb of 18 centimeter, left upper limb of around 17.5 centimeter. Tricep skin fold thickness test was not done. The blood pressure was 130 by 70 mm Hg in the left arm supine position with a mean arterial pressure of around 90 mm Hg, pulse rate of 90, which was normal, respiratory rate was 20, SpO2 of 96%. On examination, there was no paler cyanosis, clubbing, or generalized lymphadenopathy. Scalp hair appeared sparse and axillary hair were also sparse. Icterus was present, but there was absence of nutritional deficiency like bitoid spot and the presence of any xanthelasmas. Oral cavity examination was normal with good oral hygienes and no findings suggestive of glossitis, cheilitis, or parotid enlargement. Neck and examination revealed no thyroid abnormality and a normal JVP. There were no spider nevi over chest and back, but gynecomastia was noted. There was no palmar arrhythmia or deprettance contracture seen. IV cannula was noted on the right hand. Skin had scratch marks present with shiny nails and no petechial rashes. Joint examination was normal, and other peripheral stigmatas of CLD or internal malignancy was also absent. Sterility test could not be performed as patient was confined to bed with a performance scale of ECOG 1. Coming to the systemic examination, on inspection, abdomen was uniformly distended, umbilicus pushed downward and everted. Flanks appeared full and all quadrants moved equally with respiration, and overlying skin appears stretched. There were no visible veins were seen over the abdomen and back region. No visible pulsation or peristalsis was noted. Palpation, skin temperature was normal with mild generalized tenderness present, but no associated guarding or rigidity. Liver and gallbladder were not palpable, but spleen enlargement was present 3 cm below the costal margins along the splenic axis, and it was firm in consistency with rounded border. Hepatojugular reflux was present. Examination of external genitalia, hernial orifices were normal. Abdominal girth of around 90 centimeter with a measurement of xiphisternum to umbilicus 17 centimeter and from umbilicus to pubic symphysis 14 centimeter. Percussion, shifting dullness was noted but no fluid thrill. Prop space was dull on percussion. The upper border of liver dullness was percussed at 5th intercostal space in mid-clavicular line with lower border percussed just above the costal margin, giving us the liver span of around 10 centimeter. Auscultation was normal. Per rectal examination was normal. CVS RS was normal. CNS, there was no flaps noted or any other focal neurological deficit. Number connection test was normal. Peripheral sensations were normal. No neck stiffness or pupillary reaction to light were normal, and a mini mental score examination was 26/30. So, sir, because of the absence of any visible veins over the abdomen as well as back, and the presence of hepatojugular reflux, only being the definite significant findings with the splenomegaly, and the provisional diagnosis remains same. It is a cholestatic jaundice in a patient of decompensated cirrhosis of liver with the performance scale of ECOG 1 with portal hypertension and moderate ascites, splenomegaly, decompensation in the form of ascites pedal edema with clinical evidence of mild abdominal tenderness, which can be suggestive of query spontaneous bacterial peritonitis, and no evidence of any hepatic encephalopathy, GI bleed. In investigation, as the patient pointed out about decreased urine output, investigations are required to rule out AKI. The etiology of this chronic liver disease, first possibility can be an alcohol, but other possibilities also can be considered like a chronic HCV or HBV infection. The cause of his present decompensation can be an alcohol use which patient was denying, or as the important causes goes, it can be an infection, HCC, or a natural progression of disease.
See, I think a very well summarized case, but how do you explain the abdominal pain?
Yes,
Is it SBP which you are pointing towards, or something more than that?
So
What's in this the cause of abdominal pain is not clear to me.
Yes, sir. Because on examination, it was only a mild generalized tenderness was present, sir. No significant guarding, rigidity. The pain of abdomen was.
So I think you still would have to keep, besides spontaneous bacterial peritonitis, a portal vein thrombosis.
Yes,
should be considered an SCC, as you rightly put it there. So I think portal vein thrombosis could be one factor for causing acute pain. Should we proceed?
Yes.
All right.
Taking out the differential diagnosis of acute Butchery, all the other causes remain to be evaluated. When patient presented to us,
can you go back to that slide?
Yes, sir. Yes.
So you still think it's malignant biliary obstruction is a possibility?
Sir, the absence of gallbladder and was against it, sir. The other findings were also not suggestive of any malignant biliary obstruction, but still, sir, as it is a life-threatening disorder, I kept it to investigate the patient and look for this cause, sir, because the other causes of cholestatic with pain abdomen was not getting explained, sir.
All right. So your second possibility of autoimmune hepatitis with overlap syndrome is not within your first possibility?
Sir, the first other possibility that PSC can be extrahepatic also, sir, with the prior history of sir CLD, which can be an attribute to his AIH and not alcohol-related disorder as we are suspecting. So that's why I kept it as a different diagnosis.
Sharma, as sir told, as portal hypertension, portal vein thrombosis is one high likely possibility in this setting.
Okay,
what sir has pointed out, because that can explain the pain also, no?
Yes, sir.
Acute thrombosis can explain the pain also.
Yes, sir. So, okay.
Okay, carry on. Let's look at what is there, because we are running out of time.
So when presented to us, he had he was admitted 1 week prior at his hometown, where the investigations were done on the 19th of September. It revealed an hemoglobin of 11.5, platelet count of 51,000, INR of 1.6, total bilirubin of 21 with a direct component of 16, OTPT elevated being 104 and 98 respectively, and ALP being 198. HG reversal was there. Blood urea was 51 and creatinine was 1.6. The patient was also evaluated by the gastroenterologist, so he also tried to look at the other causes of his cholestatic symptoms at present, for which ANA was done, which was negative, ENA profile was negative, asthma negative, LKM1 negative, AMA negative, serum IgG level being normal 1110, and serum IgG4 well below the cutoff of 138 milligram per deciliter. The AFP was done, which was normal. CA99 was normal. The causes of any other bacterial sepsis was also ruled out by doing serum typhi, paratyphi, IgM scrub typhus, and IgM leptospirosis. Blood cultures were negative, stool routine normal, urine routine normal with the pus cells of around 4 to 6 and an epithelial cell count of 1 to 2 per high power field, but no crystals or cast visible. The upper GI endoscopy was showing some small varices with no fundal varices, and 2D echo was normal with IVC examined without any thrombus, and it was intact. This was the endoscopy report which was done outside, showing some small esophageal varices and no fundal varices. CT scan in view of his AKI, CT scan abdomen was plain was done without any contrast. It showed a cirrhosis of liver with splenomegaly and a dilated lienorenal collaterals, distended gallbladder with mild to moderate ascites also noted. The gastroenterologist also evaluated for his to rule out for his extrahepatic biliary obstruction. MRCP was done, which showed cirrhosis of liver with splenomegaly. Multiple splenic hilar collaterals were noted with bilateral pleural effusion and collapse of bilateral lower lung fields. Sorry, sir, the images, both the soft copy as well as the hard copy was not available. Only the printout of the report was available with the patient. It showed cirrhosis of liver with splenomegaly and moderate ascites. The initial investigations at our hospital also were more like the same, with mild leukopenia, platelet count of 1.16 lakh, total bilirubin of around 22, direct component 16.6, AST, ALT being 154, 91 respectively, ALP 213, creatinine increased almost 0.3 milligram per deciliter, and a serum sodium of 1.51 with an INR of 1.51. Within it was showing the R factor of 1.5, which was more in favor of cholestatic jaundice. Initially, we did an ultrasound abdomen review. It showed a chronic thrombus in the main portal vein, with a thrombus also extending into the right and left branches of the portal vein, coarse echotexture of the hepatic parenchyma, mild splenomegaly with mild to moderate free fluid in the abdomen.
How does your ultrasonologist tell you whether it's a chronic thrombus or an acute thrombus?
Sir, in the initially, sir, the thrombus can be an hypo or isoechoic, sir. But as the chronicity of thrombus, the thrombus becomes like they were saying that it becomes hyperechoic.
All right.
So that is. So the endoscopy was repeated at our center, which showed grade 1 varices and grade 2 varices in one column with mild portal hypertensive gastropathy. Other examination including ceruloplasmin, urine copper for 24 hours, iron, TIBC was all normal, and serum ferritin little bit high, which can be attributed to the cirrhosis of liver. Ascitic fluid analysis was normal. The cause of any other viral cholestatic hepatitis was also done. It was IgM HAV normal, HEV negative, IgM anti-HBC negative, total HBC, HCV, RN, and plasma ammonia all normal. This was the endoscopy done showing.
What do you mean by ascitic fluid analysis was normal?
Sir,
you said ascitic fluid analysis was normal. What does it mean?
Sir, it was not showing any SBP, sir, as we were suspecting the cause of pain abdomen, sir.
Okay, but we don't see SAG value here.
Yes, sir. SAG was more than 1.1, sir. As the albumin was 2.6, and here the albumin of 0.15, sir. So SAG was more than 1.1. ADA was negative, sir, in this. Culture also negative.
All right. So where do we finally stand?
Sir, still the possibility of his cholestatic hepatitis was not ascertained till now, sir.
You tell the other test, na Sharma? What are
Yes,
other tests
yes, sir.
you have done?
Yes, sir. Sir, the CCT abdomen was done at our hospital after normalization of his creatinine. It showed a cirrhosis of liver with splenomegaly, thrombosed portal vein and its branches, multiple collaterals with mild free fluid noted. These are the CT images, the coronal section showing a chronic thrombus, as well as the sagittal section showing a chronic thrombus, contracted liver, and mild splenomegaly. The follow-up labs, the patient was deteriorating. The follow-up labs were showing the same, as the bilirubin increased from 23 to 25 with a predominant direct component. The enzymes were hovering around 470, 500, and ALT being 217 to 220, ALP are around 300, with an INR almost constant at 1.51 to 1.64. In view of all these worsening in the symptoms as well as the lab parameters, patient was given an option of a living donor liver transplantation, sir, for which he agreed, and the workup was started. But during this workup, we thought that to evaluate the cause of this cholestatic hepatitis, we did further investigation, sir. To rule out any other seronegative hepatitis, we did anti-LC1 SLA atypical PNCA, which all came out to be normal. Serum ACE level was normal. LSM was 8.1. Anti-HCV DNA was negative. But our reports of viral hepatitis being the non-hepatotropic viral hepatitis revealed IgM CMV antibody positive, IgG CMV antibody positive, and IgG EBV viral capsid antigen positive. To confirm this diagnosis, we did a liver biopsy, sir. A liver biopsy also showed a mild portal inflammation with the predominant lymphocytes and fibrosis present around F2 fibrosis with hepatocytes with lobular inflammation showing mild lymphocytosis, and mild lobular and sinusoidal cholestasis was present. The pathologist reported some basophilic intranuclear inclusion bodies present. So the final impression was liver biopsy with early fibrosis and lobular cholestasis, intranuclear inclusion bodies present, suggestive of CMV-related liver disorder. So this is the liver biopsy images showing lymphocytic infiltration and the magnification images showing the basophilic intranuclear inclusion bodies. So patient was managed with empirical antibiotic UCDA antihistaminics for his pruritus, fat-soluble vitamin supplementation, IV terlipressin at the dose of 2 mg per day, and injection humanized albumin. Tablet well-gained cyclovir was started at the dose of 900 milligram twice a day for around 6 weeks, and other supportive medications for primary prophylaxis of hepatic encephalopathy was given. The patient showed a significant and a rapid response. These are the investigations. This was done on 3rd of October. From 26th of October, when the patient was discharged, the bilirubin came down from 21 to 9. Enzymes also came down from 280 to 106, and ALP almost getting neutralized from 170 to 135. This is the recent investigations when the patient presented to us, as the patient is now in the list for DDLT and is in the waiting list, and now he presented to us just for the routine checkup on the just 1 week back. It was also showing a normal CBC, a bilirubin of 1.8 with the complete normalization of the enzymes and the ALP level, and a protein of 4.3 gram per deciliter. So as the question of ACLF versus acute decompensation was also raised in the chat box, and it is a common differential, sir. I would like to have it as a review in the literature. ACLF, as per the APASL criteria, has more of an hepatic insult, but in DCLD it can be an hepatic or a non-hepatic insult. The identified precipitants are present in around 95% of patients of ACLF, but only around 70% cases of DCLD. The time from insult to presentation is defined by APASL as within 4 weeks, but it is variable in DCLD patient, and it can range up to 12 weeks also. The underlying cirrhosis may or may not be present in the to label a patient of ACLF, but it should always be present in a case of to label a patient as a DCLD. There should not be a prior history of decompensation, and mortality rates are also low. But in case of DCLD, there can be a prior decompensation episodes present, and mortality rate are little less. But as per the Sarinsa paper, the reversal or recovery is seen in almost around 50% of cases, but it is very uncommon in cases of DCLD. Coming to the review of literature, the CMV is the...
You have only about a minute or two, because we need to have 20 minutes for the second presentation.
Oh, sir. So these are the few articles, sir, which we were able to find, sir. This is a case report of a 35-year-old male patient with no significant prior medical history, who presented with 2 weeks duration of fever and as well as jaundice. The patient's CMV antibodies were positive, and PCR testing was also positive. Patient was also started on well-gained cyclovir, which resulted in a rapid improvement. So this is a case report of CMV leading in an immunocompetent adult, leading to an emergent LDLT in a 39-year-old female with only a 6-week history, who presented with fulminant hepatitis. The Schlesinger also mentions CMV as a cause of an acute portal vein thrombosis, and we could only able to find out these 10 reported cases of CMV presenting as an acute portal vein thrombosis. This is a very interesting case report of CMV presenting as an acute Butchery syndrome as well as portal vein thrombosis in a female of 36-year-old immunocompetent, for which all the other hypercoagulable markers were negative, and patient was only been able to recover by the antivirals as well as the therapeutic anticoagulation started, and the partial vascular recanalization was done. Thank you, sir.
I think very, very interesting case. Usually, we don't investigate for non-hepatotrophic viruses, and very unusual to have a CMV causing the precipitation in immunocompetent individuals. So I think very nice presentation, very good case. Any points from anybody? Otherwise, we'll move on to the second presentation.
Sharma, one quick question. What are the major immune deficiencies you commonly notice in CLD? Since your exam going, we'll wind up with this.
Sir, the most common is the cell-mediated immunity, sir. The CDAI, the cirrhosis-associated autoimmune dysfunction, sir. It mostly this all the cell-mediated immunities are it is more common in a patient of cirrhosis of liver rather than being the B cell mediated problems or plasma cell disorders, sir.
I think the only other thing which comes to my mind is that in a situation like this and with COVID going on, I think COVID related deterioration should also be considered, including HLS syndrome, which is known to complicate COVID in some of these patients. And we now know that this is not a very rare sequelae of COVID. I think, of course, this case did not have it, but if I get a case like this, I'll also think of that possibility. I think this patient received only one dose of COVID vaccine.
Yes,
but then your patient presented to you 2 months after the first dose, isn't it?
Yes,
and at that time, the policy was 84 days.
Yes, that time it was the Covishield vaccine he took, sir. So the second dose was not.
All right, very interesting case. Let's move on to the second presentation. We have only 20 minutes left. You have too many slides, but you have only 20 minutes.
Okay, sir. Thank you, sir, for giving me the opportunity. Good evening to all. Myself, Dr. Mamaheshwara Stungavarappu from General Hospital, Coimbatore. Today, I am presenting general presentation. This is a recent article published in Clinical Gastroenterology and Hepatology, a systematic review and meta-analysis of monogenic inflammatory bowel diseases. Coming to introduction, inflammatory bowel disease is a disease of intractable chronic intestinal inflammation that is classified broadly into Crohn's disease, ulcerative colitis, and few are undetermined. And genetic factors, abnormal immune responses, microbial dysbiosis, and environmental predisposing factors are thought to cause the inflammatory bowel disease. IBD and IBD-like diseases that are caused by monogenic variants with Mendelian inheritance patterns have been described as monogenic IBD in contrast to typical idiopathic polygenic IBD. Advances in next-generation DNA sequencing made it possible to genetically diagnose these patients, and these monogenic forms of IBD are rare, severe, and refractory to the conventional therapies. Especially when we have to consider these monogenic IBD forms is age of onset, family history, atypical endoscopic findings, severity, atypical infection history, and extraintestinal comorbidity. These are the factors we have to consider monogenic rather than polygenic IBD. Recently, European Society for Pediatric Gastroenterology Hepatology Nutrition agreed on a consensus list of 75 monogenic IBD genes. The number of reported cases of monogenic IBD has increased in recent years, but they covered mostly on very early onset IBD that is occurring before 6 years of age, but they didn't include monogenic IBD cases. And in addition, there are no detailed reports containing a comprehensive picture of monogenic IBD with specific numbers and age distributions, proportion of extraintestinal comorbidities, relationship of extraintestinal comorbidity, age at onset, are detailing the clinical course of monogenic inflammatory bowel disease. So to review these clinical questions, conducted a systematic review of all published cases of monogenic IBD. Coming to methods, inclusion criteria, peer-reviewed articles, including clinical information about a monogenic IBD case or cases, which are published between January 2000 to December 2020, in which genetic testing was definitely performed and in which gastrointestinal manifestations were marked directly as IBD or IBD-like by the investigations, including ulcerative colitis, Crohn's disease, intestinal parasites, and granulomatous colitis. The excluding criteria were articles not published in English, articles with previously published cases, and articles not containing the details of individual cases and intervention clinical trials. Then what is monogenic IBD? They are caused by gene variant which was damaging and rare and known to cause a monogenic disorder from previous reports, and it is consistent with patient's clinical phenotype. Coming to the flowchart of the systematic review, using PubMed limited to the English language, they searched with gene names and monogenic disorder names and abbreviations. All the titles and abstracts were screened. Then full text articles which are relevant were taken, and from these full text articles, reference lists were searched, and relevant full text articles are included, and they applied for the eligibility criteria. After that, they removed the duplication articles. Finally, 303 articles were included for the systematic review. And the systematic review covered 303 articles across 31 countries, and they included 750 cases of monogenic IBD, in which 472 were males and 259 were females, and in 19 cases, gender was not reported. Coming to the cases and articles for causative genes, in these 303 articles, they covered 68 genes of 75 genes. For remaining 7 described monogenic genes, the articles did not meet the inclusion criteria. And more than half of the monogenic IBD genes that met the inclusion criteria not had more than 5 cases. And genes not included are out of 6 genes, articles not described GA symptoms as IBD. Instead, they described as enteropathy or chronic diarrhea. In addition, for one gene, only the abstract form was available during the time of review period. Coming to the modality used for genetic diagnosis, there has been a dramatic increase in the number of articles reporting monogenic IBD cases since 2012. This was presumably because of increased awareness and widespread use of next generation sequencing. The use of whole exome sequencing appears to be increased from 2012, and the use of target gene panel sequencing appears to increase from 2017. Coming to family history, consanguinity, and inheritance patterns, family history of IBD was noted in first and second degree relatives in 23.1% of cases, and consanguinity was noted in 21.7% cases. And autosomal recessive pattern of inheritance was the most common pattern of inheritance noted in 62% cases. Coming to variant types, missense was the most common variant type in 45.7 cases, and then followed by frameshift and stop gain mutations. Coming to deletions and introns, they are reported in few cases, but which are sometimes challenging to identify with whole exome sequencing and target gene panel sequences. Coming to IBD subtypes in the systematic reviews, Crohn's disease was labeled in 34% cases, and ulcerative colitis in 6% cases, and IBD in 49.5% cases. Rest were IBD unclassified in 2.7%, intestinal biceps in 1.7%, and granulomatous colitis in 6% cases. What are the most common reported genes in this systematic review? Most common was interleukin-10 RA gene, which is noted in 124 cases, followed by XIAP gene in 69 cases, CYBP gene in 68 cases, IL-10RB in 33 cases, and LRBA gene in 31, and also TTC7A in 31 cases. Coming to age at IBD onset, for 71 cases, age at IBD onset was not provided. And in this infantile onset IBD, that is from 28 days to 2 years of age, was the most common group of 28.2%, followed by the infantile onset IBD from up to 27 days. And very early onset IBD, that is up to 6 years of age, constituted 63.4% of cases. And 10 to 17.9 years included 17.4%, and 18 years onwards, 10.9% cases. Coming to the extraintestinal comorbidities before the onset of IBD in each age group, And clear information about extraintestinal comorbidity onset was not provided for 144 cases. Of 606 cases, 31.7% had extraintestinal comorbidities before the IBD onset. And most of the patients in the infantile onset and neonatal onset, they don't have extraintestinal comorbidities prior to the onset of IBD. Whether most of the patients, that is more than 50%, had extraintestinal comorbidity before the onset of IBD after 2 years of age. Coming to the monogenic IBD cases for underlying monogenic disorders. The most reported monogenic disorder was interleukin 10 signaling colitis. That includes genes IL-10, IL-10RA, IL-10RB genes, including 164 cases, followed by the chronic granulomatosis disease, included 99 cases involving CYBA, CYBB, NCF1, NCF2, and NCF4 genes, followed by the X-linked inhibitor of apoptosis XIAP deficiency, that is in 69 cases. Coming to age at the IBD onset and monogenic disorders. Most cases of IL-10 signaling colitis and TTC7A deficiency and RIPK1 deficiency, the onset was within 6 months of age. 6 months of age. Coming to Hermann-Pudlak syndrome and familial GUCY2C deficiency syndrome, they occurred mostly in adult onset. Coming to XIAP deficiency and chronic granulomatous deficiency, chronic granulomatous disease and haploinsufficiency A20, they occurred in varying ages ranging from infancy to the third decade of life. Coming to extraintestinal comorbidities before IBD onset versus monogenic disorder. So almost all cases of glycogen storage disease type 1B and Niemann-Pick disease type C, they had extraintestinal comorbidity before the onset of IBD. And cases of interleukin 10 signaling colitis, PTC7A deficiency, and chronic enteropathy associated with SLC2A1 gene, they don't have extraintestinal comorbidities before the onset of IBD. And most of the cases of chronic granulomatous disease and XIAP deficiency, they are the most commonly reported cases. They also not manifested extraintestinal comorbidity before the onset of IBD. Coming to the extraintestinal comorbidities and GI complications, the most commonly observed extraintestinal comorbidity was recurrent severe atypical infection, noted in 44.7% cases, followed by skin, nail, and hair abnormalities, noted in 38.4 cases. Then autoimmunity, noted in 21.6% cases. And the GI complications in the form of perianal disease and oral ulcer, they are noted in 35.9% and 15.1%, which are the manifestations usually noted in non-monogenic forms of IBDs. Coming to hemophagocytic lymphohistiocytosis and macrophage activation syndromes, they reported in 25 cases across 4 genes, most of which were noted in XIAP cases. Coming to malignancies, they were noted in 18 cases involving 8 genes. And IL-10 signaling colitis were associated with lymphomas and IPEX-like syndromes, including genes LRBA and CTLA4. They had lymphomas and gastric cancers. And TTC7A deficiency associated with Langerhans cell histiocytosis. And the NCF4 gene, which is responsible for chronic granulomatous diseases associated with the anal adenocarcinomas. Coming to the therapeutic strategies, previously attempted treatment options for these severe monogenic IBD cases were surgery, biological therapy, and hematopoietic stem cell transplantations. Coming to surgery, out of 750 cases, bowel surgery was performed in 27.1% cases, that is 203 cases. Of 203 cases, bowel dissection was performed in 128 cases, that is 63.1% cases. Most of the patients of TTC7A deficiency and interleukin signaling colitis, they required surgery early in the disease course. Coming to the age distribution, there is similar surgery was performed between ages less than 6 years and more than 6 years after the onset of IBD. Coming to biological therapies, of 750 cases, biological therapy received in 247 cases, and it was effective in 25.5% cases. Coming to biological versus gene, for Hermansky-Pudlak syndrome, that is type 1 and 6 genes, it showed 100% effective. 7 patients received and 7 was effective. Coming to anti-TNF agents, not effective for interleukin signaling colitis, that is IL-10RA, IL-10RB genes, and also for IPEX-like, that is LRBA gene. Coming to biological drugs used and their targets, these are the conventional biologics used commonly, both for polygenic and monogenic. Other extra biological tried were abatacept in LRBA and CTLA4 deficiency, and interleukin 1 targets in mevalonate kinase and NLRC4. Coming to hematopoietic stem cell transplantation, hematopoietic stem cell transplantation was performed in 23.1% cases, and it showed effective in around 70% and failure in 42 cases. Out of 42 cases, 30 were died, and remaining 12 cases, there was no improvement. In this LRBA gene, TTC37 and TTC7A, IKBKG, which is associated with the nuclear factor kappa B, essential modulator deficiency, they didn't show any improvement. Coming to hematopoietic stem cell transplantation gene, as we discussed, for CYBP and NCF1, NCF4, which are associated with chronic granulomatous diseases, these showed most effective, and also for XIAP deficiency and LRBA deficiency, and also interleukin 10 signaling colitis. They showed higher success rates. But for TTC7A and also discussed for IKBKG, it showed decreased effectiveness. Biologicals and hematopoietic transplantation as per monogenic disorders. Biologicals, including TNF alpha agents, they showed good effectiveness for Hermansky-Pudlak syndrome and not effective for interleukin signaling colitis and chronic granulomatous disease. And for chronic granulomatous disease, it is lethal also. Coming to hematopoietic stem cell transplantation, it is effective in interleukin 10 signaling colitis, chronic granulomatous diseases, XIAP deficiency, and IPEX-like syndromes. And it is not effective, as discussed, TTC7A and IKBKG genes. Coming to discussion, they reviewed published articles around 30 across 6 continents, which is representing a diverse ethnic background. And this study provides comprehensive picture of the heterogeneity of genetic mechanisms underlying these diseases, clinical presentation, and responses to therapy. Another strength was it not only covered very early onset IBD, it also included adolescent adulthood. And majority studies thus far on monogenic IBD were before 6 years of age. Diseases such as IL-10 signaling colitis, chronic granulomatous diseases, XIAP deficiency, IPEX-like disease, and TT7A deficiency, which are widely reported, should be considered based on clinical presentations, enabling early diagnosis using target sequencing, like Sanger sequencing or target gene panel sequencing. On the other hand, more than half of all monogenic IBD genes that met the inclusion criteria in this review had fewer than 5 cases reported. So in terms of utility of age at diagnosis of monogenic IBD, patients presenting before 6 years of age account for majority of cases, that is 63.4%. Adult onset and adolescent monogenic IBD cases represented 1/3 of cases. These findings differ from the previous reports, which showed more prevalence for children younger than 6 years of age. It could be because of genetic testing was generally pursued less aggressively for adult onset and older pediatric cases than for those younger than 6 years of age. So clinicians should suspect monogenic IBD more than previously thought, especially if a patient has extension comorbidity or shows refractory response to conventional therapy, even if a patient is not younger than 6 years of age. Many of the reported monogenic IBD disorders, including chronic granulomatous disease, XIAP deficiency, CEAS, and HEA20, they're difficult to differentiate from typical IBD because they present across a wide range of ages, and there is infrequently a history of disease-specific extended comorbidity before IBD onset. This is especially early diagnosis is especially useful for chronic granulomatous disease and XAP because hematopoietic stem cell transplantation developed before development of HLH for XAP deficiency and anti-TNF agents use can lead to severe infections and even death in chronic granulomatous disease. For the variant types such as copy number variants, intronic variants, synonymous variants, and inversions, they are often missed by whole exome sequencing. So the advantages and disadvantages for each genetic detection method should be considered when investigating a patient for monogenic IBD. So in terms of therapy, 46 genes responsible for monogenic IBD received biologicals. So many of the cases who received biologicals had few number of cases. And monogenic cases linked to 15 genes showed 0% efficacy from biological therapies. Some treatments like CTLA4 fusion protein, that is abatacept, showed effectiveness for LRBA and CTLA4 deficiency. And anti-interleukin 1 targets like anakinra and canakinumab showed effective for nevernet kinase and NLRC4 genes. However, the use of specific biological in most monogenic IBDs has not been established and should be used with caution. And in this study, hematopoietic stem cell transplantation showed effectiveness in 70% of cases. This could be an overestimate as a result of reporting bias.
We are running out of time. Can you go to the conclusion, please? It's already 7:01.
Okay, sir. 2 minutes. Sir.
Just summarize, yeah? Go to the summary, yeah.
Okay, sir. So, when there are red flags like onset less than 6 years of age, especially less than 2 years of age, a family history of consanguinity, autoimmunity, infantile deaths, in clinical course in the form of severe disease, refractory to IBD treatment, complicated perianal disease, or extraintestinal comorbidities in the form of atypical infections, skin diseases, nail abnormalities, hair abnormalities, autoimmunity, lymphoid abnormalities, dysmorphic features, chronic lung disease in the form of bronchitis, pulmonary fibrosis, interstitial lung disease, HLH and mass-like symptoms, malignancies, then we have to consider for functional screening or directly genetic sequence appropriately, like Sanger sequencing, target gene panel sequencing, whole exome sequencing, whole genome sequencing. Then after confirming the variant, then we have to consider for the treatment according to the confirmed variant, like surgery or considering hematopoietic stem cell transplantation, especially for IL-10 signaling colitis and chronic granulomatous disease, XIFA deficiency, IPEX-like syndromes, and IPEX syndromes. And not considering hematopoietic stem cell transplantation for intestinal forms of disease like TTC7A and TTC37. And considering specific biologicals like Hermansky-Pudlak syndromes, TNF alpha targets, CTLA4 and LRBA, CTLA4 targets, and MVK NLRC4 interleukin 1 targets, and genetic counseling should be offered. Thank you.
Are the genetic sequencing available easily? Do you have any idea?
No, sir.
Because see, this type of IBD is recently being given a lot of importance, particularly when you have unusual presentation in the childhood. But then I personally feel that it's very difficult to prove what they are. So this genetic sequencing, to my knowledge, is not commercially available. Any idea?
In few centers, it is available, sir.
In India?
In India, it's available, sir. Bangalore, in the Pune.
As a Bangalore-based firm, sir, they are doing whole genome sequencing.
Okay.
They also import this SNP kits, which is not available in India. The kit has to be procured abroad, but they can run the machines. Thanks to COVID, they can do genomic sequencing nowadays in Bangalore and Hyderabad. Both are available.
Okay. I think this was a very good presentation. We hardly discussed this this type of IBD in various forums. So I think we have run out of time. Any final comment? So thank you very much, and back to you, Mr. Singh.
Thank you very